Okay, so we're going to finish up. I believe this is now week 4. So with this particular week, week 4, we have chapter 18. Chapter 18, we went over all of the different types of cardiac issues, I should say. So it's alterations in cardiac function. In the beginning of this chapter, one of the main topics we talked about was coronary heart disease. Okay, please make sure you know everything there is to know about coronary heart disease. Keep in mind that this is where now we have this lipid panel. Okay, so the blood on the laboratory value sheet, your lipid panel will include the information for this. Also keep in mind that one risk factor also coronary heart disease is also patients that are diabetic. Okay, so please make sure you keep that in mind, because if we need to do any type of screening also for these individuals, we will also look at their glucose. Okay. Make sure you know the difference, obviously, in HDLs and LDLs, okay, and know their values and know what their functions are. And know the entire pathogenesis of atherosclerosis. Okay, so know the whole pathogenesis of atherosclerosis, what happens as far as the injury and the plaquing and all that. Now, before I continue on, just to make sure you guys know the difference. What's the difference between atherosclerosis and arterial sclerosis? Now, we talked briefly about this in chapter 14, I believe. We went over that chapter during that week. What's the difference between our arterial sclerosis, just think of the name, and the atherosclerosis? Not the vein. Arthro is the artery, the main artery, I shouldn't say the main artery, but the artery itself, whereas arterial is the arterioles. Okay, arterial sclerosis is the arteriole. Now, just going back to basic physiology, why is the arterioles important in blood pressure regulation?
Because they come right after the arteries?
Because they come right after the arteries, but then also they have some kind of mechanism. Okay, very good. It has what they call a variable, not a variable. It's not a sphincter, but they say that these vessels have able to open and close. Okay, so whether we want to call it a sphincter or not, but they're able to open and close. And keep in mind, when they open and close, this now regulates blood flow through the rest of the circulation, therefore regulating blood pressure. Okay, so please understand that anytime a person has even an atherosclerosis and definitely arterial sclerosis, this can definitely offset their blood pressure, okay, and put them into a hypertension. So just keep that in mind. So the reason why I'm saying that, just so we can tie all these things together. Now, the other thing with this chapter, make sure you go over, obviously, acute coronary syndrome, okay, which we went over in detail. So making sure you know what happens if a person has what is called the STMI, non-STMI, and what is just a basic angina, okay, or unstable angina. Also make sure you know the different types of angina. And also with the different types of angina, we did also introduce some medications such as nitroglycerin. Okay, and we also talked about calcium channel blockers. Okay, so just make sure you know what those meds are and what they do. Make sure you also understand too with the coronary diseases, In the PowerPoint, there were a couple of flow charts that went over, okay, if the cardiac output is low, and then how that actually not getting enough blood flow and not enough oxygen in the blood flow, and how that damages the tissue and causing not enough oxygen and the sodium potassium pumps and all that. So just make sure you go over that flow chart, okay, to understand the pathogenesis of what happens, okay. Keep in mind too that when there's a couple of things, and let me just find that flow chart. The flow chart is in chapter 18, slide 21. Slide 21. So when there's a lot of, I shouldn't say a lot of, when there's an issue with not enough blood getting to the cardiac muscle itself, there's a couple of things that can happen. One thing that can happen, as you can imagine, is a dysrhythmia. Okay, so the rhythm of the heart is going to be offset. Okay, and the reason why the rhythm of the heart gets offset is because the ions start to leak. Okay, now have you ever heard of patients having maybe electrolyte imbalance and then leading them to a heart attack? Okay, or having heart issues? That can happen. Okay, because of the ions. So when these ions are off balance, it can also give these individuals that issue. So I'm going over this so you can understand how to tie this together. The other thing here, as you know, when the heart muscle tissue breaks down, we know that it releases those cardiac markers, which is the C, K, and B, and the troponin. And another thing you should keep in mind is, and I didn't put this as a laboratory value, but when a patient lacks oxygen, when we're talking about cellular metabolism, it then goes which route? Aerobic and anaerobic? Anaerobic route. So when it goes to anaerobic route, now these individuals will start to build up what? Lactic acid. Okay, so just keep that in mind, and that is also another process in the physiology that goes on with this. Okay, and when that lactic acid builds up, this can now also cause other cellular changes. Okay, and we'll revisit this again when we talk about shock. Okay, now sudden cardiac death, we talked about that. That's easy enough to memorize. Now, valvular diseases. Okay. Please make sure you know the difference between a stenosis and a regurgitation. And we had 1, 2, 3, 4, 5 valvular diseases that I do need you to know. Okay, so there's 5 different types of valvular diseases. So this will be our mitral stenosis and regurgitation and so forth. With those diseases, please make sure you know obviously which chamber is affected. Make sure you know what's going on with the heart as far as the flow, the blood flow. So for some of you that may have issues with answering these questions, it would be good if you can just, if you have the, if you take a piece of paper to just kind of draw the heart, okay, and maybe just draw the blood flow if you forgot the blood flow process. So in case if we talk about it, say the mitral valve is stenotic, okay, what's happening now to the left atrium, okay, and what's happening from there forward, okay. Make sure you know the description of the sounds, okay, the description of the sounds. Next term, I'm going to try my best to have those sounds on the test for the students. But for now, I didn't have a chance to do that. Yeah, you guys are missing it. You're missing it all. Missing all the good stuff. Yeah, next term, week 10, I'm really going to change up Patho. Not completely, but the class, I think I told you guys I'm actually flipping the classroom for the students next term. And so a lot of the nursing courses are like that, so I'm going to completely flip, which is one of the reasons why I videotape all the lectures. So what's going to happen, they're going to watch the lectures at home. Class time will be just pretty much a recap, and then a lot of case study, critical thinking assignments and class assignments. and testing and things like that. So that way you don't have to come and sit and do a lecture for 5 hours. So it's going to be a little different. Students, I don't know how they're going to take it, but it'll be okay. They'll figure it out. Okay, so that's that for the valvular diseases. Okay, so again, just make sure you know the descriptions of the sound, what's going on with each chamber. Okay, so everything that you studied the last time. Now, for endocardial diseases, there was only, I think, 2 or 3, well, really 2, that I focused on. So just make sure you know the rheumatic heart disease and infective endocarditis. Okay. Now, what's a risk factor for infective endocarditis?
Bacterial infection.
Yes, bacterial infection. Well, the bacterial infection will cause the endocarditis, but what's a risk factor? There's a valvular disease that's a risk factor.
Oh, the one where they're, but I forgot.
Yeah, the mitral valve prolapse. Okay, mitral valve prolapse. That is very important to know, and I think they still do this, but for those patients, just to let you know, that have mitral valve prolapse, they will give them antibiotics, okay, before they have any type of surgery done, just to decrease their chances of getting that bacterial infection in the heart, okay? So that's important to know if a patient has that type of prolapse, okay? Okay, now, chapter 20 was shock. Okay, now with shock, couple of things here I do want to point out with shock. Make sure you know the pathophysiology of shock. So in the beginning we went over the pathogenesis of actually what happens at a cellular level. So we talked about the anaerobic metabolism. We talked about the free radical production, and we also talked about the macrophages, okay? So that is all in your PowerPoint. The anaerobic metabolism, the free radical production, and the macrophages. That right there is the pathogenesis of what happens on the cellular level with shock, and this is any shock, okay? So this is explaining what happens at the tissue level. Make sure you understand that just in case if I do have a pathophysiology question related to shock, okay? Now, let me just list for you the types of shock that I want you to focus on. Well, first of all, there's this box here, box 20-1. It's in your PowerPoint and it's also in your book, box 20-1. That box, I do need you to know, it should be in the beginning if you go back the other way. Box 20-1, that particular box, box 20-1, I want you to know the different types of shock and the examples that fall under that category, okay? So box 20-1 with the little green box in the book, because I will have a question with that. Now, going back to the different types of shock I want you to focus on. We went over in detail cardiogenic shock. We also went over in detail obstructive shock. We went over in detail hypovolemic. Anaphylactic. And septic shock. Okay, so we went over those shocks in detail, which means I want you to know those in detail. Yes?
What's the difference between sepsis and septic? Because I see sepsis someplace.
Okay, sepsis just means the inflammation. So sepsis is the widespread inflammation that the person has in their body. So it's the infection, pretty much. Sepsis is the infection. And sepsis is an infection that happens pretty much all over the body. So it's not just tailored to one organ. Then septic shock is when that sepsis gets to the point where now it leads to a lack of blood flow, okay, getting to different organs. That's the shock portion, okay. So a person can have sepsis and then the sepsis leads to a septic shock. But they have to have the sepsis first. And keep in mind, sepsis falls under that category of what we call a distributive shock, where it dilates, okay? So the vessels dilate now, open it up, and so when the vessel dilates, you're thinking, oh, we have enough blood flow, but no, that's not the case. The blood does not have enough pressure for it to flow in the direction it should. So the blood is actually stagnant. Now, speaking of septic shock, okay, and not only just septic shock, but what are some complications of shock that you know and remember from that chapter? So remember, a person can have shock and then they can have some complications, other diseases or conditions that can come from having that shock. ARDS, very good. So ARDS, acute respiratory distress syndrome, very, very good. Very common as with septic shock. Okay, the one you just talked about, very common with septic shock. What else? Very good, renal failure, acute renal failure. Why the kidneys? Keep in mind that the kidneys filter about 1/3 of blood. So if that blood's not moving, the kidneys are going to suffer. Okay, so these patients could have acute kidney failure or renal failure. What else? DIC, very good. Disseminated intravascular coagulopathy. With this, keep in mind DIC, and I explained this before, these patients do have hemorrhage. That's number one, they hemorrhage a lot, but then they also clot. Okay, so as much as they're hemorrhaging, they're clotting. So this is where they get the simultaneously bleeding and clotting. But the number one sign is them hemorrhaging. Okay, so I don't want you to think it's the clotting the number one, but the number one is hemorrhaging, bleeding kind of all over the place. Okay. And then what is the last complication? Okay, good. MODS, which is multi-organ dysfunction. Am I saying that right? Dysfunction syndrome? Yes, dysfunction syndrome, which means this is now talking about organ failure. So this is where the kidneys are affected, and then just say, for example, maybe the liver shuts down, maybe the heart is having issues, okay? So this is now involving multiple organs. This is also very common in patients that have sepsis or septic shock, okay? It's multi-organ shutdown. There's no pictures with shock. But with shock, I could have laboratory values, okay, such as maybe the bleeding, what is it, the coagulation? I'm losing it. Blood clotting, thank you. Blood clotting assessment. I could also have a blood count, okay, with maybe the patients that have shock, okay? So just keep that in mind. There are some laboratory values that can be associated with shock. So maybe just a regular CBC with diff, and definitely blood clotting assessment for those that may be going into a DIC or something like that, okay? Okay, so that's that. Week 5, I think, yes. Week 5, we had chapter 22 and 23. Chapter 22, we did obstructive pulmonary disorders, and with that particular chapter, we only focused on really 4 different disorders, which, I think 4 or 5, 4. Yeah. Asthma, we had acute bronchitis, chronic bronchitis, and then emphysema. I think we had maybe one picture from this, maybe 1 or 2 pictures from this chapter, just to let you know. Keep in mind with chapter 22, this is where the new information I told you to highlight, the arterial blood gas assessment. This is where this now can be part of this, okay? So the arterial blood gas assessment could be a part of the respiratory disorders. Now, what can you tell me? Just tell me something about asthma, whether it's a hallmark or the pathogenesis or a treatment. Tell me something that you know about asthma.
Genetically predisposed.
Okay, very good. Most of asthma is the allergic form, which is the extrinsic type. Very good. What else? I'm sorry, somebody said something.
I said it's genetically predisposed.
Okay, yes, and genetically predisposed, and so remember they do have that genetic for atopy, and those individuals, if you saw in the PowerPoint, they do have certain chromosomes, okay, where they do have this genetic information that they do have this type of sensitivity. And what else?
Reversible.
It is reversible, very good. Asthma is reversible, okay? Not like when we talk about chronic bronchitis and emphysema, okay? So yes, asthma is reversible. What is the cellular adaptation that occurs with asthmatic patients? There's a cellular adaptation that occurs in the bronchioles with these individuals.
Mucus, like the term valvular.
Okay, very good. So keep in mind that it's an actual hyperplasia of goblet cells. Okay, so it's a hyperplasia. Hyperplasia is a cellular adaptation of goblet cells that happens with these individuals with asthma. Okay, and so we know that they produce too much mucus and that clogs up the airway. Okay, very good. Now, what can you tell me about acute bronchitis? Just tell me something. It doesn't have to be the full shebang. But what do you know about acute bronchitis?
Inflammation of the bronchi.
Okay, it's inflammation of the bronchi, yes. And that inflammation of the bronchi usually comes from what?
A virus.
Very good. Okay, so most of the times these are viral. So just like some of these people that left us today were sick, and the individuals at West Coast here are sick. These individuals do have a type of virus, okay, where the cold virus, and now this cold virus gets down into the bronchi. Okay, very good, giving what you said, the inflammation. Okay. Keep in mind that again, most of this is viral, so unless it is a known bacteria, antibiotics will be used only for those bacteria type of infections. Other than that, keep in mind that treatment is just fluids. Okay, patients do cough a lot with this, and just giving them cough suppressants. Okay, so just kind of review those treatments. Now, when we talk about chronic bronchitis, give me some of the hallmarks. It has kind of some fancy, I shouldn't say fancy, but some hallmarks that stand out.
Overweight patient.
Overweight. Okay, so we know that these individuals are overweight. What else? What else is a hallmark of chronic bronchitis? Blue bloaters. Okay, so we call them blue bloaters. Blue because of, they turn blue because of, what's the term? Cyanosis. Very good. So they are lacking oxygenated blood, or oxygen, excuse me. They're lacking the oxygen, therefore the tissues start to turn blue. Bloating because of what? Not only because they're overweight, but something else that makes them bloated. What makes a person appear bloated? Very good. Excess of body fluids, which is a term called edema. Okay, so keep in mind these patients do have edema, especially tissue edema in this situation, and so they will have that appearance, okay, of the bloating. Okay, now what about emphysema? What are some hallmarks of emphysema? Puffer, yes, they call them pink puffers. Pink because the tissue gets pink for some reason. I'm not sure the physiology behind that, why it's pink instead of blue. But puffing, why are they puffing? They can't breathe, but what do they call that kind of breathing? There's a term for that, and I saw it in an NCLEX book, so please make sure you don't forget that kind of breathing. Pursed lip breathing. They have pursed lip breathing. What are some other hallmarks of a person with emphysema? Very good, they're thin, okay? So they're skinny, thin individuals, mostly males. What is a risk factor amongst all of these COPD conditions? Smoking. Okay, still want to pick your brain. What is a complication of a person? If a person has an emphysema, what is a complication that can happen to their lung and to their heart? Say that again. Okay, carpulmonary is one. Carpulmonary can happen, which is right-sided heart failure. But before we get to the carpulmonary, what happens in the lung? So keep in mind, yes, you can. The term is pneumothorax. Okay, the term is pneumothorax. So yes, I know you said pushing, I know what you meant, pushing the heart. So with the pneumothorax, keep in mind that patients with emphysema, they can have what is called a spontaneous pneumothorax, okay, which means that they will start to develop these blebs because the lung is filled with air, okay, and this air is just like kind of making these pockets, and those little pockets of air can burst. When it bursts, this can now cause this person to have air in the pleural space, now pushing the heart all the way over to the side. Yes, they will definitely have heart issues or carpulmonary with that, okay? But that's not really the main thing with carpulmonary, but it could be part of it. But the main thing is that, yes, they will have heart issues from that or heart failure. Please make sure with chapter 22, okay, that in this chapter, much like the leukemia chapter, it does have all the different things highlighted. So there are a lot of different diagnostic tests that go along with these diseases, okay? Please make sure you go over those. So obviously the blood work, looking at the white blood cell count and so forth, the eosinophil rate. Keep in mind that these patients will also have chest x-rays done. They can also have bronchial provocation testing. So there's a lot of different diagnostic tests that go along with these diseases. Make sure you go over all of them. Okay. And that was that for 2022.
What is productive and then productive cough? Like, are you going to test us on this?
Well, with the productive and non-productive cough, it all depends on how much mucus they have, honestly. But most of the obstructive pulmonary diseases do, I'll say this. So most of the obstructive pulmonary diseases, they do have a sort of productive cough, okay? When we get into restrictive pulmonary diseases, they don't have much of a productive cough. It depends on which one we're talking about. But the obstructive ones have more of a productive cough because that mucus is blocking the airway. With the restrictive pulmonary disease, it's more just an inflammatory issue, mainly. But again, to say if it's productive or non-productive, all depends on how much mucus they're having. Okay? But I'm not going to get into like the color of mucus, which white is whatever, and green is bacterial, and white is white. We're not going to get into that. But just know there is a difference, not not productive and productive. Okay, 23. Chapter 23, we went over restrictive pulmonary diseases. And talking about restrictive pulmonary diseases, this is really more so an issue at the alveoli level. Okay, so just keep that in mind. Mainly at the alveoli level, and mainly talking about the pleural space. Okay. Now, remember with the pulmonary or respiratory diseases that we do have pulmonary functional testing. So I'm not going to ask you, okay, well, is the expiratory reserve volume and different values like that. But just make sure you know, and I'll put, if I put in a case study, I'll just put if it's normal or abnormal. Okay, so obviously we know that they'll be abnormal, okay, with the pulmonary diseases. But I don't want to give you extra stuff to memorize, okay, so we'll leave the ranges out. Now, with 23, we did have quite a bit of pictures, okay, so just make sure you know, and I think there's a whole tab on images for chapter 23 on e-college. So there are quite a bit of pictures in chapter 23. Make sure you go through each and every disease. I'm not going to name them all, but make sure you go through each and every disease. Make sure you go through the diagnostic testing, okay? There is actually more diagnostic testing in the chapters on respiratory than any other chapters, okay, just to let you know. So please pay attention to that. Now, I'm going to start to run out some questions. Give me some hallmarks of sarcoidosis. Okay, one main hallmark that we should know of sarcoidosis. Don't forget that. What is the hallmark of sarcoidosis? That you can find in the lung on a chest x-ray. Thank you. The granuloma. In particular, non-caseating granulomas. Okay, and I believe I explained that to you. Non-caseating mean that this granuloma is just a mass full of immune cells, okay? And they call it a granuloma, not to say that this is a benign tumor, so to speak, but it's just a mass full of immune cells. And when we talk about something non-caseating, mean that it's very well defined and it's hard. I don't want to say very, very hard, but it's not soft, okay? Which means if you remember me showing you the pictures of it, it's very well defined and it looks like you can just kind of pull it out, okay? So please make sure you don't forget that, okay? That is one of the main hallmarks of sarcoidosis, non-caseating granulomas. What else can you tell me about sarcoidosis? What are some other maybe signs or symptoms that patients have with sarcoidosis? Something that stands out that's different than any other respiratory disease that we talked about.